automatically, if you will. What was the movie about the cyclists in a race in Colorado and one was sick? I can't remember the name of it. Anyway, you can see them on the bicycle, and they've got a ventilator that they're grabbing with their teeth, and it's measuring the amount of oxygen they use because you can convert oxygen usage to ATP usage and calorie production. Less dramatic ways of doing this is just put the person in an enclosed space, and they can measure the decrease and the addition of oxygen to that space. We have a simplistic structure here called a dry spirometer, differentiating from a wet. A wet was just a box of water with another box, so you would have water here, another box placed upside down with a tube, and when you breathe into that tube, it would raise that box, and a little chain would kind of measure which way. But with all that moisture, it was more conducive to bacterial growth inside the tubing and everything, and so we switched to just using the dry spirometers. With both of these, the problem with them is that they can only be measured with expiration. You can't breathe in and measure what you're breathing in. You can only measure what you're breathing out. But we can use math and adjust for that. So when we look at the charting that occurs, so let's say someone is doing this continuously, and we're charting this on a graph. So I'm not going to make the inspiration shorter and the expiration longer just for ease, but you do remember that you're going to breathe in for less time than you're going to breathe out. So breathing in and breathing out like a tide, coming in and leaving the beach, is known as tidal volume. So the average of one inspiration or expiration is that single breath. We're not summing things up. And hopefully what you breathe out is the same as you breathe in and breathe out is the same. The average for this is given as 500 mils. But remember, breathing is a voluntary process regulated by reflexes, which can be affected by emotions and conscious thought. So when you're thinking about taking a breath, you're going to adjust what that volume is. So if I just take what I think is a normal breath, and then breathe into this, without using that showed about 500. Let me try it again. This morning it was like 250.
You were tired.
You're getting your momentum.
No one's not even moving. So if you take a few, average them out on Thursday, you can get your average tidal volume. Now, if you then take in as deep a breath as you can above that, all right, then that entire volume is your inspiratory capacity. What you can completely breathe in.
That was one of my questions.
And what you can breathe in above your normal inspiration is identified as your inspiratory reserve. So if I take in a normal breath, and then all the rest of that would be my inspiratory reserve. I don't need all of that volume of air every day. Okay? If I'm running, then I need additional oxygen. I'm climbing stairs, and I'll start taking deeper and deeper breaths. If I'm at altitude, I'm going to be taking deeper breaths because there's fewer oxygen molecules per breath when I'm at higher altitude. And therefore, I need to take a deeper breath just to get in the normal amount of oxygen. All right? So that's what we use the inspiratory reserve volume for. And these values are given, these are done by averages. Okay? So inspiratory reserve volume is around 2,000 to 3,000, depending on whether you're male or female.
Bless you.
And the capacity would be around 2,500 to 3,500, the addition of the tidal volume to that. This morning when I did it, it was about, I think, 1,500. So to measure this, remember I can only blow out. So to measure this, and we'll go over these steps if we use this instead of the biopacks on Thursday. So you would take in as deep a breath as you can, and you do that better standing up than sitting down. Whoops, I better set this at a normal value here. And then you want to breathe out until you're passive. You don't want to start forcing air out. So you breathe out until it feels comfortable and you're not using your abdominal muscles. This machine must be broken. I got to about 400. I did have to do hot, but I was broke, but I should be able to breathe better than that. Nope, that's 500. You guys don't have to go very far to beat me on Thursday. All right, now, when we breathe down, take a few more comfortable breaths, and now we're going to force air out until we can no longer force any more air out, and that is our expiratory reserve. And that's about 1,000 to 1,200. I will never, yes.
I'm just gonna ask, in the chart, it shows it, and it's about the title, does it matter that you did it on your chart over there?
No, a tidal, it's at the end, what it is by definition is just, once you've passively expired, and then you start forcing air out, doesn't matter where it is along here. It's just once you start forcing air out past the passive expiration, until you can no longer force any more out. That's the expiratory reserve, okay? So, you breathe in, doesn't matter how much you breathe in to start. Breathe out, around, outside, and then put it in and start forcing the air out, okay? I'm really poor, or else these machines are bad. It came to 200. Let me try that again. I just can't breathe today.
Have you started exercising? Because you said you started.
No, I haven't been exercising, but I should be. I can still run up the 4 flights of stairs at Sex State without any problem. I think it's a machine. We'll try it on the machine. All right, so there's still air in my lungs. I have not completely collapsed all of my alveoli. All right, so there's still air in my alveoli. There's still air in my bronchioles that I can't move out. And so that volume that is left over is called residual volume. It's what's left behind, and it's about the same volume as expiratory reserve. If we add inspiratory reserve to tidal volume to expiratory reserve, we get the maximum amount of air that you can move in and out of your lungs, and that's defined as vital capacity. So it's equal to inspiratory reserve volume plus tidal volume plus expiratory reserve volume. And you'll notice on the chart that it says average is 4,800 mils. I think I got to about 1,200. Normally I get to about 29. Okay, 20 between 25 and 29. This is actually based on your gender. So males are going to have more lung capacity because they have a greater oxygen drive. They need more red blood cells because of the greater muscle mass. It's also based on height. So a taller person typically has more lung capacity than a shorter person. And it is to some degree based on ethnicity. All right, so Native Americans, East Indians tend to have lower lung capacities. However, they don't typically say where they got that average of 4,800, but I think they got it from a group of 20-year-old Coast Guard applicants. Because we have this table, males on this side, females on this side, and it has a chart starting with the age of 16 and going to 70, 74, and height. Now the height is in centimeters. So it's 2.54 centimeters per inch. So it goes all the way up to 194 centimeters, and I believe this morning they said that was 76 inches. All right, so in males, a 16-year-old at 6'4" should have a vital capacity of 5,000. It drops down to 4,800 by the time they're 24. So essentially, this little group of males has an average of 4,800. Not all males, but this group, from 16 to 24 if they're over 6 feet. So this area covered up my fingers are the ones that have 4,800 or higher. Okay? And even higher is only to 5,000. If we look at females, anywhere on the female, even the 6'4", 16-year-old female, its maximum vital capacity is at 3,900. So for text to publish the average at 4,800 is rather skewed. So when we do this for lab on Thursday, I want you to figure out what yours should be for your height and your age, rather than putting down the 4,800, because you're going to feel really wimpy if you think it has to be at 4,800, all right? So for female, mine is supposed to be 2,900, between 29 and 3,000. And this morning, I think I got 1,500. So I think it's the machine. We'll see on Thursday. Yes?
So what would they use this for setting up?
Well, we're going to look at that next, okay? So there's one more test, which is a functional. These are just normal airflows, all right? There's another one that we can do with the spirometer. There is another test called functional expiratory volume. And it is a ratio, a percent of the amount of air that you can breathe out in 1 second, sometimes done as 2 or 3 seconds, divided by your overall vital capacity. And when you look at the chart, depending on how it's done, it will go this way or it will go up. But essentially, what's happening is when I take in as deep a breath as I can, all right, so I'm not breathing out, I'm taking as deep a breath as I can, and then I start to force it out as rapidly as possible. This is my maximum expired air. So this is my vital capacity. In this test, it's called the forced vital capacity, but it should be equal to my vital capacity. It's just I'm trying to do it as fast as possible, all right? So if this time is at 0 seconds, and at 1 second, and 2 seconds, so if I extrapolate where my volume, expiration volume is at 1 second, that is my forced expired volume. at 1 second, abbreviated FEV1. Okay? So when we do a ratio of that, at here, my forced vital capacity was 5 liters. At 1 second, if I approximate that, it's, well, up here, 4 liters. So if I take my FEV1 of 4 and divide it by 5, that comes out to 80%. So when we see this, it's done as a percentile.
What's the
What's
fund?
the five?
The 5 was my vital capacity.
What's the abbreviation for 500?
Forced FVC is forced vital capacity.
That's me.
Like you.
Yeah. Oh, I'm sorry.
Was a professor.
How's that?
Thank you.
Does that look like an F or an E? So forced vital capacity. So the maximum volume that you breathed out divided into the volume that 1 second, or it's done at 2 or whatever. You can see an FEV2. But the most common is an FEV1. And the value is most important not as an actual number, but as a percent divided by your overall vital capacity.
So 25% is really bad.
That's really low. Normal is anywhere, depending on the text that you read, 80 to 84%. All right? So here's what someone who has asthma or emphysema, the problem with those two diseases is the airway is narrowed. When you breathe in, remember that pressure within the thoracic cavity is lowered. That helps to expand the airways. Now when you breathe out, it's already narrowed because of asthma or the emphysema, and so you're trying to push more air out. What do you do to do that? Use your abdominal muscles, use your chest muscles to increase intrathoracic pressure. What's that going to do to the diameter of the airway? It's going to make it even smaller. All right, so it's more difficult for these individuals to breathe out. So when we look at an FEV test for someone like that, they may actually have a normal vital capacity, but it takes them a much longer time to expire that air. So at 1 second, they're somewhere short of the normal FEV. So their volume, their FEVs could be anything less than 80%. Would be considered an obstructive pulmonary disease, something that's blocking the airflow. Because of this change, right, because of this difficulty in blowing air out, they often tend to leave air behind. And so they end up with a greater overall lung volume because air is trapped.
The elevation really affects them as well. I know.
And it's because they're not mixing, they're not getting rid of that high CO2. So we have two different types of pulmonary disorders. It can be confusing at first because the terms seem to mean the same. Obstructive means there's a block. So let's say that there's this large cave that you're supposed to have a party, all right? And so you're walking through a tunnel to this large cave. In obstructive pulmonary disease, that tunnel has a big rock in it, a big boulder that you're trying to get around. It's blocking your way through that tunnel. But when you get to the room, it's the same size. With restrictive, there's nothing wrong with the tunnel, but when you get to the cave, there's been a collapse. And half the cave is missing because the walls and the roof have caved in. That's restrictive. Right, so let me draw an illustrative schematic on the board. So this would be normal. Normal diameter airway, normal volume of the alveoli. Okay? With obstructive, the airway is narrowed, therefore it takes, especially with expiration, and the alveoli may be the same or actually larger. So the key is a decrease in FEV1. It takes longer to breathe out, Therefore, FEV1 is typically lower than 80%. Because it takes longer to breathe out, we tend to have an increased residual volume. Air ends up being trapped in the lungs, and it's difficult to get it out. So the overall lung capacity gets larger. Typical diseases that reflect these conditions are asthma, emphysema, and just a whole class of inflamed bronchi called chronic pulmonary disease, COPD. Bronchitis, bronchial carcinoma, where tumors growing into the bronchi. Anything that is affecting the conducting pathway, all right, rather than the respiratory zone.
So say COPD?
COPD. You guys can't read my letter.
Chronic bronchitis. Something.
There.
Pulmonary distress. I don't know what that stands for.
Charlie, Omega, I don't know what P is.
Cop donuts.
What?
Cop donuts.
Hot.
Cop
Oh,
donuts.
okay.
Oh, wow, maybe that's why you can't write.
All right, then restrictive has to do with the site of gas exchange, all right? So you would have a normal airway, a normal conducting path, and then the alveolar, the gas exchange site, is going to be blocked for some reason. It may be collapsed, all right, or it may be blocked with fluid. So pneumonia. Now I'm self-conscious about my letters. Pulmonary edema. Put that off. Any collapsed lung. Tuberculosis.
What's that?
Tuberculosis is a bacterial infection that the body tries to rid itself of by walling, creating a wall that blocks off the location of the infection, but it also blocks off that site for gas exchange.
Doesn't it usually stay up in the upper parts of the lungs?
Fibrosis.
Okay? So here we have a decreased capacity, a decreased lung volume because of the collapse of the cave, rather than a narrowing of the tunnel. So just lung cancer rather than bronchial cancer, all right, where the alveoli become solid. So small cell, oak cell type lung cancer rather than specifically bronchial cancer.
So then with the normal FEV, but then it drops lower.
So what happens in that previous diagram, so if this was normal, and we had 80% of our air expired by the time of 1 second, but if it takes longer, you would still get to a normal expiratory capacity, but it would take you 5 seconds to get there instead of 3. And at this point, you may only have 60%. So within 1 second, because your airways are so narrowed, you would only have expired 60% of your air instead of 80%. Okay? Now with restrictive, if we were to do this same test,
You might
and
lose
this
your
is 80%,
It's 80% of a lesser number.
right, you might have, this would be higher, so your vital capacity itself would be lower, and this would still be 80%, but this overall capacity would be lower. You have a lower volume. All right, so one more concept here, and that's pulmonary ventilation versus alveolar ventilation. So you already should be comfortable with pulmonary ventilation. That's just the movement of air in and out of the lungs. And on page 52, I believe, there's a table that shows pulmonary ventilation versus alveolar. Now remember, our airways include, most of the airways are conducting pathways. So gas exchange is not possible because there is an absence of simple squamous epithelia and alveolar air sacs. And so with pulmonary ventilation, it's just the amount of air that is moving from the nose to the lungs. So we measure that by taking tidal volume times respiratory rate. But the last little bit of oxygen that you breathe in is still in your vestibule. It's not all the way down in your alveoli. So that's not alveolar ventilation. Okay? So if our average tidal volume is 500 mils, and our average respiratory rate is 12 times a minute, then our pulmonary volume comes out to about 6,000 mils per minute. But remember we talked about anatomical dead space.
150.
An anatomical dead space is essentially the volume of our conducting airways. Where their gas exchange cannot occur. So your pharynx, your larynx, your trachea, your bronchi. And this equals approximately 150 mils. And we'll just take that as our standard number. It's going to vary, obviously, with size. So now to get true alveolar ventilation, we need to subtract that anatomical dead space from our tidal volume. Because only what's left over is actually reaching gas exchange surface area. So if we take our normal tidal volume minus 150, we get 350 times 12. And I think I have that on the table.
50. 52.
52. All right. So that changes from 6,000 to 4,200, a little over 4 liters. It actually reaches the gas exchange area. The other two sets of numbers on page 52 reflect the effect of deep inhalations. So if you take very rapid but shallow breath, I notice your alveolar ventilation is actually 0. So that obviously isn't compatible with life. So let's change it to 350 mils and a respiratory rate of 20. Okay, almost twice normal, yes.
Is that way you pass out if you're hyperventilating?
Two things, hyperventilation actually by definition is rapid but deep breathing. So you're breathing off the CO2, and that's more of a factor. So if we minus our anatomical dead space, instead of, we get about 4,000 mils here, even though we have doubled our breathing because we're so shallow, even just a little bit shallow, all right? So if we increase the depth of our respiration, I think on the example there I have 1,200. That's not difficult to do, to breathe in 1,200. And we decrease that to 5 breaths a minute. By the time we subtract our anatomical dead space, I think we're at 5,200 something, a little over 5 mils. So it's much easier to increase the amount of air getting to